Hello, I'm Roger McIntyre, Professor of Psychiatry and Pharmacology at the University of Toronto in Toronto, Ontario, Canada. My pleasure to be sharing with you results of the Thinc tool validation. Why, what, when, and how to use this recently validated tool sensitive at detecting cognitive dysfunction in adults who suffer from major depression. Let me, in fact, if I can, begin with a brief outline of this presentation. We're first going to discuss a rationale for evaluating cognition in depression. I'm going to press the point, this is a common dimensional problem in depression and it mediates functional outcome. I'm also going to speak to the relevance of depression in the real world today and the shift towards the cognition, the complex work environment. Then we'll move into a discussion about the use of the tool itself and how this tool was constructed, what are its component tools, and how in fact you would be using it in day-to-day clinical practice. Let's start off, if we could, by having a brief look at the ecosystem that our patients live in. This is the third revolution. The first was the agricultural, the second was the industrial, and we're now in a digital revolution. We hear words like machine learning, artificial intelligence, automation, and many languages like this that speak to how the economy is changing. And what's happening is that employment opportunities are increasingly available for those persons who work in non-routine jobs that are cognitive and complicated in skill sets. What this implicates is depression. Major depressive disorder is not only a common disorder, but a disorder that is often chronic, and a disorder that involves cognitive disturbance. Let me show you some data from a recent publication from our group. What we in fact were able to show is that when you look at people who suffer from depression, we know many don't have full functional recovery. And what was interesting to me in this analysis is that when individuals in fact were evaluated their overall depression severity as well as their cognition symptoms, it turns out what really in fact mediates a person's ability to go to work and perform at work is their overall cognitive abilities, more so than their total depression symptom severity. Taken together, what this means, as we work with patients to improve functional outcome, we need to assess the overall depression severity, but we also need a separate measurement of their cognition. Over the years, what I have learned is that many people have different understandings and ideas as to what's meant by cognition. And these are the four domains of cognition. Starting with executive functions, we move through memory, attention, and processing speed. These are the four atoms of cognition hierarchically arranged. Yes, they're related, but they're all very different. And all four of these domains are affected in people with depression. Now, one other type of way to think about defining cognition is not only executive function, attention, memory, and processing speed, but what's referred to as hot and cold cognition. And simply put, cold cognition is non-emotionally valence cognitive functions, simply memory and processing speed and coordinating your thoughts. We also have what's called hot cognition, and this is emotionally valence cognitive functions. In other words, cognitive functions that are affected by your emotion. Patients who ruminate, who constantly think about negative events or negative themes day in, day out. Or patients who have exaggerated or catastrophic reactions to real or perceived slights. As clinicians, we always see patients with depression who have attentional biases. They're biased towards events in their environment that are highly negative indeed. These examples of rumination and exaggerated reactions to slights, as well as, in fact, attentional biases, represent examples of what we call hot cognition. So as we think about cognition, we start with vocabulary and we define what cognition means. It also, I think, is important to emphasize how common these problems are. Obviously, cognition affects people with depression. It's one of the criterion items. Over 90% of people with depression have cognitive problems while depressed. What's important to emphasize is that about half of patients with depression have cognitive problems even after resolution of the mood symptoms. And no doubt, for many of these patients, these ongoing cognitive difficulties decrease quality of life and decrease their overall functioning. I'd like to show this slide because this slide provides empirical evidence supporting the assertion that the magnitude of deficit that we see in cognitive functions is clinically relevant. So we benchmark clinical relevance on the basis of an effect size of 0.2 to 0.5 4, 0.4 to 0.8. These are small, medium, and large effect sizes. What we know is if you look at the results from meta-analysis, as this slide indicates, what we find is that the overall cognitive deficits we see in depression across the domains that I described earlier range from about 0.2 to 0.7. This is in keeping with what we think is highly clinically relevant and therefore demands our attention. Many clinicians will see patients who are presenting for the very first time, their very first episode of depression. And there's no doubt that people who have more chronic, more multi-episode depression are more likely to exhibit cognitive problems or report cognitive problems. This was a report in people who had a single episode of depression, their very first episode, and at that first episode, they also exhibited cognitive problems. So cognitive problems in depression are seen during the first or subsequent episodes. The more episodes you have, the more likely you'll have them, but you'll see the first episode, and these cognitive problems persist between the actual episodes themselves. Now, along with episode frequency and illness duration, there's other factors that will influence the likelihood someone will have cognitive problems while depressed. For example, does the person have comorbidity, like drug and alcohol misuse? Do they have medical problems, like obesity and diabetes? We know that these are conditions that decrease cognitive abilities, just like having disturbances in thyroid. So as clinicians, there are factors that are not modifiable, such as a person's age, and factors that are modifiable, like illness severity, illness duration, episode frequency, comorbidity. These are factors we can work with our patients to achieve, yes, better functional outcomes, but also reduce the likelihood they're going to have cognitive problems. One of the questions that often arises is, well, don't we already have measurement tools for depression, such as the PHQ-9, the Beck Depression Inventory, the HAM-D, the MADRS? And indeed we do. We have tools that can assess the totality of depressive symptoms, but these tools do not provide sufficient evaluation of a patient's cognitive domain disturbances. They don't have enough items, and they don't give us a sufficient insight of the complexity and circumstance, how cognition affects that individual in their day-to-day life. Finally, these scales actually rely on self-report of cognition. And what we've learned is that self-report of cognitive problems do not correlate with objective measures of cognitive function. Finally, screening tools for cognition deficits like the mini-mental status exam, well known in dementia, are not sufficient for clinical practice in depression. They don't have sufficient sensitivity. So with that, there is in fact a need to develop a new tool. Cognitive problems are certainly very common. They mediate functional outcomes. They're important for quality of life. And the magnitude of deficit demands our attention. So what are we looking for in a particular tool? Well, there's many features which we call psychometric characteristics. Is the tool sensitive? Is it reliable? Is it valid? Does it, in fact, allow it to be applied to different cultures, different countries, people from different backgrounds? And these are aspects we had in mind as we were developing this particular tool. One thought we had as we were developing the Thinc tool is, why don't we go to existing measurement scales that are out there? Let's start off with, in fact, how the tool looks. So the tool is gamified, it's digitalized, and it's downloadable from the internet. And the tool itself is something the patient will administer, not the clinician, the patient in the waiting room while they're waiting for their appointment. It takes about 10 to 15 minutes to complete it, and this is a visual of how the actual tool looks. The tool is comprised of many different subtools, and one of the subtools is the DSST, the Digit Symbol Substitution Test. This is a paradigm that's been around for 100 years, and this tool assesses many domains like attention, processing speed, and memory, and we have our own version of the DSST. Many would know the pencil and paper version as illustrated in this graphic, but what we have in the Thinc tool is we have, in fact, the digitalized version. The patients, in fact, can complete the digitalized version in the waiting room, and it's timed out to 90 seconds. Other components of the Thinc tool are known as the spotter, which is a reaction time test. The person simply just hits the button that corresponds with which arrow is pointing. The other test is a version of the NBAC test, which we call the symbol check, where the respondent anticipates what's the next symbol and hits that symbol that corresponds with the symbol on the top line. This is a measure of working memory. It's a very complex test indeed. Finally, we have the TRAILS B test. The TRAILS B test is a measure of executive function. It looks at cognitive flexibility as well as memory, and the respondent simply connects the dots. It's important, as I hinted at earlier, that we have not only objective measures, but also subjective measures of cognitive function, and we've included the PDQ-5, the Perceived Deficits Questionnaire 5. This is a sensitive, reliable, and valid tool of, in fact, cognitive function. Again, self-rated measures of cognitive function provide some insight, but we also need the objective measures together, and that's what we have in the Thinc tool. What's so important is that we're all busy, offices are busy. How will this information be stored? Well, the device itself can keep a record of your patient. It will not only show how they perform on the total score, but also give you a breakdown of how they perform in each of the subcomponents, and we'll keep that on record. What we learned is that about half of patients with depression who went into our study, half, had clinically significant cognitive problems. This is a very common problem indeed. And also, you can track your patient's performance across time. So giving you measurement-based information across time, allowing you to inform your patient, educate your patient, and also, I think, providing helpful information as to which treatments we should be selecting and sequencing. So to, in fact, summarize, the Thinc tool is the first validated, sensitive, and reliable, freely available, digitalized, gamified tool that's capable of detecting cognitive dysfunction in depression. We also know that cognitive dysfunction in depression is not only common and a criterion item, but it can be, in fact, a progressive phenomenon. Why it's so important is that the deficits we see are clinically relevant and contribute to psychosocial impairment, workplace impairment, and reduced quality of life. It's my belief that using a depression tool like the PHQ-9, along with the Thinc tool, provides for us as clinicians an opportunity to sharpen the focus, bring measurement to the bedside, and I think improve health outcomes for patients who suffer from depression. Thank you very much for joining me for this program.
Is Thinc a depression diagnostic tool?
The Thinc tool is the first screening tool for cognition deficits in adults with depression. It's freely available, it's digital, and it is downloadable. This tool does not, in fact, diagnose depression. The diagnosis of depression is arrived at clinically. We would encourage people to use a rating scale for depressive symptoms like the PHQ-9, and then also to screen for cognition deficits in those with depression with the Thinc tool.
What clinicians can expect to see as depressive patients' results while using the Thinc in regular clinical practice?
Using the Thinc tool in regular clinical practice, the patient and the clinician can expect to see one of three outcomes. When the patient completes the Thinc tool, they're going to get a code green, yellow, or red. Green means the cognitive functions are, in fact, as expected for someone of that age, that gender, and their education background. If the code is yellow, it means they have half of a standard deviation below the healthy controlled norms. Or red means a 1 standard deviation or greater reduction in cognition. If the code is yellow, we have to pay close attention. Is there some other factor contributing? If the code is red, that's telling you and your patient that the extent of deficit demands clinical attention. So either green, yellow, or red, like a traffic signal, will in fact inform us what we should do next for our patients.
Is it needed to use the Thinc to prescribe vortioxetine?
No, the Thinc tool is not required to prescribe any antidepressant, or for that matter, any modality of therapy like cognitive behavioral therapy. The Thinc tool is a screening tool that will detect the deficits in cognition in individuals with depression. And this is part of the overall comprehensive multidimensional assessment, but it's not required to prescribe vortioxetine.
How do I evaluate the results of patients that are not familiar with digital tools like the older ones?
Many patients we see, including but not only older patients, are not as familiar with how to administer a tool like the Thinc tool, which is digitalized. It's on a tablet, a smart device. And what we did is we built a tutorial into the actual device. We asked patients to complete a little exercise before they did the actual Thinc tool, and patients told us that they found it very helpful, very explanatory, and very simple to understand. So there is a tutorial or brief education lesson just before they do it, and the touchscreen technology is very, very easy, according to what we thought it would be, but also to what the patients actually, in fact, told us. And many patients we had in the validation, in fact, had very little familiarity with technology, so we think it should not be a problem.
Real-life patients are not in a controlled environment, like in clinical trials. How to evaluate and register biases that might interfere with cognition and are associated to patients' daily life, like alcohol or caffeine intake and sleep deprivation.
I think it's absolutely essential in any patient we see with depression who's not functioning as well or has cognitive problems or both, we try to identify secondary causes, asking the patients about psychiatric comorbidity, medical comorbidity, concomitant medications, their sleep habits, their exercise habits. All of these factors need to be looked at. Our job is simply to find out which of these factors is contributory, which of these factors is not, and can I modify the factors that are contributory? And I think, in fact, this is part of the multidimensional assessment of patients with depression, modify the factors that are influencing cognition, and be aware of those factors, and in fact, educate patients on how we can do just that, modify the factors.
Did the validation study establish the median values for the population with depression and cognitive dysfunction, considering age, gender, and education?
Indeed, the values that we obtained in the Thinc validation study in adults with depression 18 to 65 were in fact validated against a healthy control group. And the healthy control population was matched to the people with depression on age, gender or sex, male, female, educational attainment, and also people who were healthy controls could not have had a past history or family history of severe mental illness. So the norms were based on age, sex, and education match controls.
What about the practice effect in the Thinc IT tool?
One of the limitations in interpreting any cognition test as potential for practice effect, people in fact get better at the test. And so how do we know that the improvement is not just because they're practicing, rather than their cognition improving? Well, we, within the Thinc tool, have different digital versions of the subtests. And we believe that that will reduce the contribution of potential practice effect as a confounding variable. So the change that we might see with the Thinc tool across time, we feel strongly is not going to be explained largely by practice effect because we have different versions of some of the tests.